ذكر الكروم اوكي. يعني قاعد بمشي بلود. والله يجزاك الخير صراحة. هيو خلاص اطلع من النت كامل. اكس.
I'm going to sit here.
اعمل اكس. ارجع الزوم. نعم.
See the screen. I know I can see that screen. Make sure I'm not getting.
سكرتها. سكرت.
No, I'll leave that one. That one's already connected to the website. So, well,
في more and المور كبسة ريكورد. ايش اعمل؟ enable كلاود ولا كمبيوتر؟ كمبيوتر. recording in progress. خلاص بلش لايف ستريمينج. صحيح مضبوط. خلاص شيرنج. بفتح الفايل. تمام 100%. خلاص تسلم والله بكل احترام. Sure.
you just
Move the table.
Move the table just a little bit.
This way.
Just want to see the screen.
Is it enough?
Maybe we can push that back.
Maybe that's
push that.
بس هو يمكن هو يعني كان بيقدر يتعامل غير مع الموقع.
That's fine. Okay.
battery.
Yeah, I just need to.
So you want to share? Which file do you want?
I need to get to see if the images
From
for whether Multisem has copied them to the two X-rays for uploading.
the X-ray.
Because I'm going to need.
معتصم
دكتور معتصم صور
الاكس راي موجودين عندك؟
So I'm going to need.
بعت اياهم والله عندي.
So that's my talk now. But also we need to log on. Okay, so that's logged on. Just need the two
X-rays.
The two X-rays which are on the stick. The images. No, the AP is actually like. You've got. No, you've got this.
USB.
Yeah, USB.
But I mean, we start with just for talk. Not slide for just. I have to, I need presentations. Slides.
I have, yes, for the tips and tricks.
We can go all together here.
Then for the setting it up.
I'm sorry. سوري أهل الباشا. بالإيمجز مهندس والله نزلهم وقتها.
الانكل هات الانكل الويند انفكشن ويند انفكشن حاجه انكل
نزلت هناك مهندس نزلت على الكمبيوتر هناك صح؟ مهندس علي نزلت الفور على الكمبيوتر هذا اول واحد
هاي
بمجلة الشيت فين؟ Why is that not? Okay. That's the lateral, and this is AP. Why there's an external?
يلا خلينا نرتب أمورنا بس.
والوقت على 3
بس أنا يقول خلينا نضيع كراسي.
But then I just need to, where was it? Here we are.
شباب يلا. بس هسه لا. بعدين الجهاز. شباب يلا. لا ما راح نشتغل. الآن راح نقدم شغلتين. tips and tricks for programming and how to install or mount in the TSF. So first we will have around 20 minutes, 25 minutes. It's just tips and tricks by Ricky Gary. And then we will divide into 2 groups. One group will be applying the device. The second group will be doing the programming. So now it is just talks. Just please don't leave that, please. Thanks. So Dr. Gary, thanks.
Thank you. So I'm just going to these are sort of some tips and tricks. It's not like there's always alternatives. None of this is, is, you know, there's always room for discussion. So first thing I want to say, when do I not use a TSF? For straightforward limb lengthening, all of these you can use a TSF on, but I also have some emotional attachment to Ilizarov as well. So I will also use Ilizarov. So when do I not use a TSF? So I use Ilizarov for limb lengthening. For trauma, so this case, so, you know, clearly you could use TSF for that, but I quite like spending time. It's very boring for everyone else, but in theaters, because obviously with Ilizarov, you have to have the fracture reduced at the end of the operation. With a TSF, you can do the reduction later on, but I quite like that process of getting it reduced and using pull wires and push wires and arch wires and all that stuff to get it reasonably aligned. So bone transport, I'll show you some example. You can use TSF, stacked TSF for bone transport, and I'll show you a case which I've done, but I found it quite difficult. So now I would go back to use just a transport ring with an Ilizarov frame. Foot deformity correction, again, you can use the TSF foot deformity. I haven't learned that. I learned how to do it with an Ilizarov, and I can't be, I'm too old and too old-fashioned. I can't be bothered to learn all again for the TSF, but you can do it with TSF, but I personally will use foot frame, Ilizarov for foot deformity correction. And finally, upper limb. I have done 1 or 2 upper limb TSF. It may be better with the beacon, but I found it very difficult to get consistent AP lateral views. Everything wasn't quite right. And so the deformity analysis was difficult because there's not much, a lot of struts, and I couldn't really see what was happening. So now it would be Ilizarov with something like this radial club hand. I'd use this. This is a Orthofix mini rail, but that has its own problems, and in particular, this connection here comes loose, not very strong. So I don't think that's a great thing either. But anyway, so just going to talk a little bit about some of the things that I've sort of found. So stacked TSF. So this will be like for maybe a segmental fracture, bone transport, or other things. So if this doesn't apply with the beacon, but if you don't have a beacon, then I would use the middle ring, as I said this morning, as my reference ring for both frames, because you only have to get x-rays just on one ring. With the beacon, you have to have, this isn't point, but you have to have a beacon at the top and one down at the bottom, and then you still have to, then you have to get the 2 sets of x-rays. You can't put the beacon on the middle ring. So here's a case. There's a child. This is a TSF bone transport. Had about 4 centimeters of bone loss, the distal third of the tibia. And so what I've done is I'm using the middle ring as my transport ring. And so the top ring is going to get longer and the bottom pair are going to get shorter. And so it comes down. The problem is that when it comes down really short, all the struts are very short and they're very oblique. And what happens is that it becomes very stiff and it's difficult to see what's going on. So the final result was not that great. You know, there was a bit of translation down there and I found it just not. I don't know if anyone have other experience of stacked frame for bone transport, but I just found it was very, I thought it'd be very easy and you could direct, because getting onto the docking, I could direct it down, but I couldn't really see very well. And the struts were so short and so oblique. I didn't find it very helpful, so I wouldn't do. So as I said, the problems are, it's very difficult to turn the struts when they're so short, it becomes quite stiff to turn them and difficult to see the docking side. For a rotation correction with Ilizarov, it is quite difficult. I've never done, you know, there's either you have some sort of device like this. Whoops. Ah, sorry. Back. Or you may have seen this thing, this device, you know, on the set. You think, what's that for? You know, it's sort of like gathering dust, but that's for doing. You can do rotations, but it's very difficult to do a rotation correction with a Lazara. With the spatial frame, it's really easy. Sorry.
You find shifting the roads.
So here's a man. He walked into my clinic. What do we think about that X-ray? So we've got an AP view at the knee, but a lateral view at the ankle.
Yes.
Yeah, it's all rotation, but there was no trauma, no nothing. And he was, and I don't know why. Well, but it was about a 70-degree rotation, and I felt it was too much to do acutely. And with a TSF, you can probably only get about 50 degrees. I worked it out, but I thought that trying to do a rotation, the struts will probably only allow about 50 degrees of rotation. So I decided I would do 2-level rotation. I did 30 degrees at the top. Again, it was externally rotated, so I'm coming into internal rotation, and I don't want to stress the common perineal nerve, so that's my structure at risk. So I did 30 degrees at the top and 40 degrees distally. The other thing I did was I put a bit of distraction, because as the bone is coming round, I didn't want to go. I pulled it apart a little bit just to clear it. Then I can rotate it. So that's why there's a bit of distraction there. And then at the end, I then compress them back down. So I felt I wanted to get a bit of clearance to stop the bone. You understand, it's sort of crunching as it goes round. So for the TSF, you can use 2 2/3 rings. I'm going to show you. It's difficult to see it on this. This is a child who had an infected non-union, and what I've tried to do, I wanted to have a 2/3 ring proximally open here to allow clearance, and a 2/3 ring back here to allow knee flexion. But if we look at, so this is, I just drew the same on the stack here. So normally on an AP view, the master tab should be here. Struts 1 and 2. But I've rotated the whole, so this is our now lateral. There's the master tab. That's strut 1 and strut 2. I've rotated the whole ring inwards to now give me some clearance here for the soft tissues. And then there's enough flexibility to open at the back there. So it just maybe makes it a little bit easier to have slightly less bulky ring on the inside at the top. So on the software, I've put in 70-degree internal rotation to put the master tab, not anterior. Now it's very medial. But you have to tell the software that. You see, I've internally rotated the frame of internal rotation so that the master tab on an AP view, it should be here, 1 and 2, but I've rotated it round so it's there, so that on the left, it's now facing medially. The open bit is here. And then the rings, with the 2/3 rings, it just makes it slightly easier, maybe for the patient. It's not important, but it might just make it a little bit less bulky. So the master tab, yeah, it's not quite, it's anteromedial. It's come around medially. It's not quite fully medial, because there wasn't, the more medial you take it, then the open ring distally is, I'm trying to get both rings open to allow knee flexion and clearance in here. we go back, it's difficult to see it, but we have an open ring back there, and then the open ring is in here. Can't see that because of the way the X-ray is taken. And then, as I said to myself, you can mix Elizarov and TSF. So this is a girl, you may have seen her. No, it's not. Anyway, she came in a few years ago. She had this tibial fracture, treated with elastic nails. And this was at another hospital. And 5 months post-op, it's not healed up. So why is it not healed up? Infection, number one, that would absolutely, I would say, they're all infected until proved otherwise. Clinically, it wasn't infected. It didn't look infected. Sorry? No. She's a fit and healthy girl. This is just. I don't, but it was dead bone. That was where. So obviously I took samples for looking for infection. It wasn't infected, but it was dead bone. So there was a 2.5 centimeter gap there. So then I've acutely shortened her distally and then lengthened her. So I've now got TSF here. So this is TSF. Those are the Elizarov lengtheners, and that's a TSF ring there. I could have put 6, I could have done stacked TSF, but basically, for lengthening, she only has to turn 4 things rather than 6. That's the only reason. So for lengthenings, I said I would tend to use Elizarov only because there's just 4 struts to lengthen rather than 6. And then I've got the TSF here. I can still do some adjustments. So the post-op X-ray. So what a little bit of anterior translation, but I use the TSF to correct that translation. And then she's lengthening above. And as you said earlier on, that process of lengthening increases blood flow. And so that is united before the lengthened segment above had healed and does. And then finally, again, you can maybe in a situation where you want to use the TSF to assist with the soft tissue closure. So you can put a deformed frame on to help get the soft tissues closed. As long as you warn the patient, what you don't want to do is they wake up and they see their leg. You say it's going to look bent. We can get it closed, and then we'll gradually straighten it out, which is better maybe for the soft tissues. And then the final thing, these waypoints, which we've sort of talked a bit about. So let's say I want to go from A to B, but I don't really want to go over the mountain. So I'm going to go through C, and that's my waypoint. And we're going to do that. In fact, that's what we're going to be doing with the on this case of Mutatem's. We've got to have to distract it. So here's a case. That's the fracture. I put a frame on. I start trying to correct it, but the bone collides there. The bone is crashing into it. So then what I'm going to do is do some distraction, and I get so that goes. That's the waypoint, and then finally we'll go back down. And it's the same with the knee. We're going to distract it down to get it round the corner, around the femoral condyles, so you don't crash it. So because the thing about the TSF correction, if you've got the deformities, they'll all correct together unless you say axial correction first, which is what we're going to do on the so if you tick the box which says axial correction, it'll put all the length in first, then it will correct the angular deformities. And that's this concept, this idea about waypoints, so you don't crash into the 2 bones don't collide. So really, I should have predicted. I thought when I was correcting this, it was like oblique. I thought the whole thing would just slide down like that, but it didn't quite, it caught there. And so the patient, they were maybe 10 days in, and they would get a lot of pain, and it was getting really difficult to change the struts because the bone was really, really pushing. So then I thought, okay, you know, it's hitting, it's collided there. So now I'm going to change the prescription, put in the length, over distract it, and then subsequently went back. Finally, the programming, which is what we're going to be talking about. This is what it was before. That's now in the dustbin, the virtual dustbin. So the smart TSF, which we'll talk a bit about, it's very similar. If you've used this, a lot of it's very similar. So we still have steps along the top, but the big difference with the smart TSF is we can import the images into the we can put the X-rays into the program, and we can scale it using the beacon. So we're going to do all this. That's the beacon. So it sees the little metal, like little ball bearings, little balls inside the strut. And there's 16, but it has to see 12, and then it draws it on the software. We'll see that on the software, and then from that it can work out the frame orientation and the scale. We talked. Oh, it's gone. So if you don't have the beacon, what can you use to scale? Well, as we said this morning, you can use a 6mm half pin. It has to be on the bone. It's no good choosing a Rancho cube. It's off the bone, so the half pin goes into the bone. Or I can use upwards. Yeah, or I can use an olive, and I measured it. I got a caliper and actually measured. I'm a bit sad, really. I measured it. It's 4.3mm. So that's on the bone. I can use that to scale. That's it. It says lunch, but we've done lunch, but now we're just at the workshop. So any questions? That's very quick. I mean, everyone will have a tips and tricks.
Now it is like for the mounting.
Yeah.
How we will, so the way we will apply the TSF should be the
So
same
just-
for us.
Just one, was there a question? So, yes, you may decide to do the axial, lengthen it first, because if you've got the deformities will all be corrected together. So the difference with Ilizarov, often you had to do one set of corrections, then you maybe change the hinges, go back to theaters, and then do a second set. So with Ilizarov, the correction was in series, whereas with the TSF, it's in parallel. Everything's correcting at the same time. And that's when you may, if you've got overlap of bone, you have to get it out. It can't go through the bone, or if it does, it hits it. So you have to have a waypoint, and that's why on the software, both this one and the previous one, the one which is gone in the dustbin, you can tick a box, and we'll see that axial translation first. So you get the length back, then you correct any deformity or translation, get it long, and then you still may need to go back and do a second program to get back to where you want to be. So you've gone to, gone past the waypoint to C to get back.
Excuse me,
Yeah.
I may ask, when you're doing lengthening, do you always fix the fibula, or sometimes yes, sometimes?
I try and fix the fibula at each end with a wire, one at the top and one at the bottom. I wouldn't say that I try, but yeah, I usually, in fact, the very first tibial lengthening I ever did, I was very worried about the top wire and the common perineal nerve. So I really got just near the tip. And then after 1 week of lengthening, I could see that the fibula was being pulled out, was not where it should be. And I think there were two reasons. One, the fibular osteotomy, I probably didn't fully cut the bone, because I find that quite a difficult thing to do. It's a silly little bone, and it's springy and it's very mobile. but it was a combination of probably not fully cutting the bone, and my proximal wire was really just through hardly through any fibula at all. So now so then I thought, well, I can't let it carry on. It was having 5 centimeters of lengthening, and I didn't want to drag the fibula down, or more importantly, common peroneal nerve down. So then I went back to theatres, cut the fibular osteotomy again, and put another wire in, and just sort of. But the answer is yes, I tried. Yeah, I tried.
Do you use a screw between the head fibula?
Sorry, do I use?
Do you use a screw transfix between the head fibula and the tibia?
No, if it was with frames, no, I just use a wire. Yeah, I mean, you guess you could, but the wires are just like it's there. So I don't.
Okay. So now we will shift to the last part, how we will apply the TSF. We will use the same method for all to practice for the same groups. So what we will use 2 rings only, we will not add any additional rings. And what we will use the same technique as Mr. Barry is using. We will fix the first part, the proximal ring, if you can show just us.
So usually, I'll put a wire, a reference wire, parallel with the joint, and then that'll be right at the top. Now I'll bring the ring in from below. I mean, if it's 2 half rings, you can put it around, but and then fix that ring to that reference wire.
This is the first step. So we should put the wire first, parallel to the joint, then attach the ring, the proximal ring, the reference ring to this one. This is the first step done. Second step.
And then the second wire, I'll put a wire. Everyone has a different way of doing it. None of this is right or wrong. It's just a way of doing it.
To make it this.
And then the second wire, I'll put it down here. Now I've got a ring here, ring there, just with 1 wire on each. Then you can put all the struts in. Now it makes it more stable. And then I can, by changing, because they're fast fixed struts, I can rotate this ring to make it on the lateral view parallel with the joint. What I don't really want to do is to have the ring badly out of alignment. You can do, and the software will accommodate that, but I just don't think it looks a very nice frame. You know, you have it, it's like all over the place. It just looks, I don't think it looks that great. I know it's silly, it's not important, but you know, so I like to try and have each ring fixed, and the easiest way is just to wire, and then put all the struts in. Once the struts are in, then you can put in more wires and half pins, whatever you want. And I tend to go for 2 wires and a half pin on each ring, but some people will just do all half pins and no wires. Other people will do all wires and no half pins. It's not right or wrong, but I personally prefer to have mostly wires with 1 or maybe 2 half pins.
Could be some box, something below.
Yeah, usually I'll have,
Then something fix it.
yeah, so it's something, if I'll try and drop a half pin off the ring going down or up. And the only other thing to think about, if you put a half pin within the ring, between your rings, as it corrects, you have to make sure that one of your struts doesn't hit the half pin. I've had that problem, and you think I'm an idiot because I could see it was probably going to happen, but you just think about where your half pin is, make sure that as the frame, you try to mentally think about this strut is going to move that way, and I don't want it to hit the half pin. If you put it right at the front, so you've got struts 1 and 2 here and here, and you put that half pin right in the middle here, and that won't hit the struts. But if you put it like here, it could do. So if you put a half pin, so as you have struts 1, strut 2, and a half pin on that point there, goes straight in the front, that won't hit a strut.
So now we will divide ourselves into groups. The first group will be the working station group. I'm already in the so mounting session. First one is Anas Khan one. Good. Amjad and the other one. Lama Farhat. Yeah, sorry. احنا على كده
one more.
نمبر 1
تجينا مجموعه ثانيه نفك كل شيء عارفين يعني نكسر عادي محمد محسن لازم المفروض والكتاب النمبر عمر عباد الجماعة السؤال بيجي على البورد يعني البروجرام النمبر 4 محمد العناس حسن أنس الداوود محمد عطية حمزة عابر إيك حسنات أنس فرحات محمود سليحات وعزمي
Can everyone hear me? So I'm going to try and we're going to do it all together. So you should be able to log in, and I'm going to do it up here, and I'll try and we'll see how we go. So which see what that's good.
هذا الموقع مهم جدا نعرف انه احنا فايتين على اونلاين على الويب سايت هذا نضيع So we are online on this website. There is another website for United States for Europe. What is that? It's different. So if you use the website, when you go ahead, you will see your dashboard. So this is dashboard for Riyadh. And we will start with creating new page. So you will follow Mr. Bakr. So you are now what you will have. أيوة يا شباب بعد ما نخلص العملية أنت بتحط قياسات الجهاز استراتيجي داشبورد خاص هاي الورقة تكون معك بعد العملية ماشي
Yeah. Okay, so we're gonna start from the start. So create a new patient. You get through to this screen. So we're going to create a new patient. So you get through to this screen, and you put in a patient hospital number or something like that. I mean, whatever you want. You then have to tick this box, and then we can put in some details like whoops.
No need for this.
Yeah,
just go create.
And then create the patient.
كل عمل هذا step and we can just wait step by step. So have you created the patient before? Yeah.
شايف الشاشة من عندك؟
So, about attention please. More than
So we create a new frame. First thing we have to say, total residual or chronic. You know, I said this morning, it's still, we're going to total residual. So we're going to, you have to choose this. Frame name, I don't know, you can call it whatever you want, really. Diagnosis, well, this is a knee dislocation. So now we're going to scroll down. And basically is it right or left? Right. So we're going to be clicking on the right. Whoops. So we're at the knee. And then once we've we've defined the side and the side. Then we're going to start the program. Oh. Yeah. We're going to follow, we're going to take, starting here on hardware, we're going to go all through these steps. Each one goes to the next one. The first one, we have to say, what's the hardware, which is, so we're going to do proximal referencing. And you've got the ring sizes.
What is the proximal? You get your paper. يا عليان. أي ورقة عمليات.
It was a
ورقة المريض.
so
Full.
distally was that 2/3
Full.
or full ring was it? What was the start? 180. And that was between that. Okay. So once you've defined your rings, the end of the operation, I write these numbers. I write this, call out the 6 struts. I write them. I get one of the theatre nurses to write them on the board. I'll say strut number 1, 182, whatever it is. So I'll have 6 numbers, and then I'll usually take a photograph because invariably at the end of the operation, within a second, they just wiped it all up. So I take a picture of mine, then I can have that. So then when I do when I'm doing this, I've got it in my camera, what the numbers were. Obviously, I could go back to the patient and read them off. I just take a photograph. So again, the struts, we're using fast fix. So if you just need to fill in the numbers of 6, they're all fast fix, medium and short. Okay,
شباب
everyone done that step?
So هاي عشان هيك اسمها الخطوة هاي الهاردوير. يعني هاردوير انت شو الجهاز اللي تحط عليه شو زياداته so you define the hardware. Next step is
Images. So go to images. So on your laptop should be the AP lateral. So I've got it here, I'm dragging it and putting it into the. Yeah, I know.
It is done here.
Yeah, so what was, so on this image, that little green picture there means that it's found the beacon. Yours found it. Whereas here, I don't know why, it's the same picture. It's there, you can see it. But it hasn't found the beacon. And I've had this problem before, I don't know why. Try again.
So because the first one is the same image.
I know, it's the same one.
It's crazy.
Experts.
هاي الاي بي ما اخذها من الاول.
Okay, so then you just say, at the top here,
Proceed without image.
just at the top here, it says proceed without spending money on that. And then you have to
لا خليها ليه.
now you.
هي اي بي مسجلة
صح another time.
فوق انها لاترال مسجلة.
Also, these are the mountain. If you. Your images. Yes, yes, yes. I mean, so we're just gonna have to. Yeah, so we're just. I don't get this. So all we have to do is just make sure it's orientated to what it is. Until you put in. If it wasn't, then you can click on that and you can flip the image around. You can, if it was say anterior post, it was the wrong way around, you know, you can change it, so you have to get it
شهر ياخذ
into the correct. Any واحدة.
هاي لا
Well, we'll just carry on.
طيب
So you'll see if we have to choose one of these,
معتصم
one of these images.
كمل من هون
Best orientated image. Choose either.
ألف مرة امبارح جربتها وما
هي اختك عند الشباب شو في مشكلة هون
Measures. It comes to measuring length. Length is the same on both. Takes preference. whichever one.
ضبط عندكم؟
طب استنى.
But then the next step. Scale. It needs to find 12. And the AP. Yeah, it has to find the AP. Yeah, we can just do a manual. We've got. So the AP view is found the beat.
هون
And we're just gonna say, fine, we're gonna accept that one. No, this one we're gonna. AP view. Okay, so if you, what you need to do is to get those two images, you drag that one. Just make sure that. That one.
شيء
طب دقيقة خلينا ناخذ الصورة مرة ثانية على تليفوننا بلكي دقيقة بلكي ظبط.
رأي
Now this is all wrong.
أي
So
شو اسمه.
ما بعرف جهاز مين جهاز استنى
you scroll up.
طيب كيف بدك تبعثها لهون؟
مين فاتح واتساب هذا؟ هذا
علمك تعمل سكان شكله ناصر هون
And that's right, that's anterior. This was wrong, then you can flip it like that, but that's good, that's good. Fine. And we've got
الواتساب تبعه.
بس دقيقة دكتور من عندك بس تورينا
Let's say yeah, say that we change the image.
هذا لا ناصر اتوقع
بس لازم أطلع أقول لك أنا عارف إنه
ليث عمل لوج اوت ناصر من الواتساب وخايف نعمل لسه بدك تعمل سكرين خاف يفتح واتساب ويعمل لوج اوت
Yeah, that's fine. Yeah. Yes.
same
Now we go.
ما بين.
Go to scale.
continue with that.
So it's chosen the PP view. There's yeah, just take that.
ابعث لي اياها، انا طفيت. ابعث لي الصورة، ابعث لي الصورة اللي صورتها انت عن الشاشة.
ليش طلعت الشاشة؟
افتح واتساب هنا على الشاشة. نزلت واتساب. بس المرة تبعث لي جيب معك بندورة وخيار ومش عارف شو. طيب. صح؟
في غير هيك يعني حكي بده ينحكى.
خذ معي الزبالة القطع.
ليش مش ماخذ الزبالة الصبح؟ هيدا عنده لي.
So that's now asking us to. This what we didn't have the town.
لا والله بتاخذ اسهل من هيك. انا قاعد هون بحمل.
هذا الصورة اللي أنا نزلتها من الواتساب برضه على الفاضي.
طيب خليني انا احمل لك الصورة.
حمل أنت عبال ما أنا أحاول ألعب الصورة. وين الصفحة؟ سكرتها إن شاء الله. أنت سكرتها ولا أنا سكرتها من عندي؟
ما عنده سكر.
سكرتها كلها الصفحة إن شاء الله.
افتح خلاص هيو هذا افتح.
وينك؟ هي ريفرش.
لا ارجع. اطلع لفوق. اطلع لفوق. ارجع على هاردوير. ارجع على ايمج. ايوه. طيب انزل هون. انزل هون. هون.
هاي لا.
ذات. لا تبغى اعملها غلط انا.
هو تيجي.
مريض.
استنى بس.
There's no, I can't find a way of saying that.
بس كيف بدنا نلفها؟
ايوه، هي ترى بتكون المشكله انه دي لازم تكون منفوشه. هون هيها هي انا مش شايف كثير. اطلع فوق عمل فليب، انتبه للانتيريور والبوستيريور. هون الانتيريور هون لازم
ابراهيم كيف بس نلفها؟ لا، ما هي انتيرو بوستيرو يمكن ما تزبط. فليب هيك ما راح تزبط. عشان والله فيها تبع الشركة هي روتيت، بس لما اكبسها ما بعرف كيف.
دبل كليك. خلص بوستيريور هاي صحيح.
هاي انتيريور، هاي بوستيريور، هذا بروكسيمال، هاي ديستال، هاي الانتيريور.
هاي مشكلة.
هاي بس انا كتبتنا ايديت هون، تعرفوا هذا. أيوه.
ايش غيرها؟
طب رايت
هي مضبوطة بوستيريور. لازم بوستيريور لازم يكون واقف. لا مضبوط. ونعملها داونلود وخذ واحدة ثانية.
اسألوا والله بركي بيعرفوا.
اللي وديتك نفس على الواتساب؟
لا 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 سير. I don't know how to rotate this.
Okay. Okay. Well done. You've got it.
Do I have to rotate it
Yeah.
here?
So up
Then
there.
do this.
So that's correct, and that's posterior. That's anterior.
Yes.
If it was wrong, then otherwise you have to flip horizontal. But so we're going to save that. It says a moment. It's more than a moment.
You should play some music.
Yeah. Yeah. Okay.
Elevator music.
So that means that when they took the X-rays,
Yes.
they were within, before it would be like, you wanted it 90 degrees. This one, it's 82 degrees, and I think it's 65 degrees is the maximum, is what's acceptable.
The minimum.
The minimum, yes, yeah.
So.
And then we have to choose which is our best view. They both look pretty similar, but we'll go with AP. But you just have to say which one is the better view. We're going to go with AP view. Go to scale. So it's the AP view. It's found in the scale, and then we can go to the lateral view. It's found it, and then we just have to tell it where the beacon is located on the ring, so it knows. And I think it was between. I think it was between struts. Is it the beacon? What's the seven?
معتصم.
Is the beacon between struts between 2 and 3? Yeah. Okay. So now we're moving across this. So we go to deformity. These different modes, but origin and corresponding point. That's what I think. That's what. Yeah, and that's what these ones is trauma dots. I guess if you've got a fracture, but I just use origin and corresponding point. That's what I'm sort of used to doing.
Which one is related to the reference?
You mean the
Origin or corresponding?
so the origin is on the reference fragment. So I'm going to just, whoops. It's a real irritation. This always gets in the way. You can't.
Not to work without the mouse.
I
I'm not a big fan of the mouse pad.
okay, yeah, we've got that. Got rid of that. So our reference fragment is in blue. And so this yeah, so anyway, pull this over so I can get that's our reference fragment. So that's the shaft, and then the origin is this orange line here. You could drag this down. Okay. So this is where we probably say we probably want the origin to be like at the end of the femoral condyles, on the femoral side. But it's difficult to see it. Probably about here. You may see it better on the lateral view. So, and then we're going to do the corresponding point. And we know that the tibia is dislocated, it's out the back. So the corresponding point in the purple.
It has been accepted by all now.
Ah, good.
So we have to maybe.
Yeah.
I'll go back. وين وصلوا معتصم اي ستيب هم؟ هاي الفورمت
ما غيرت شيء صح؟
لا راح من اول يعني.
ارجع الصفحة.
هاي
خلاص نركز شوي. كونسنتريت شباب. الآن وصلنا لعند البيت صار خلصنا. We finished the images. We uploaded successfully images. You see how we struggled with the green and how we did for. Here, already done, just in them where feature is located. And now the format. Format analysis has three types of analysis. You can use either origin corresponding position change. We have three methods: super dot, trauma dot, origin corresponding. Mr. Fani, you using this one?
Yeah, I use that.
All of us, just click this one, go to work corresponding. And he's telling you exactly what should do. You find the mechanical access of the first thing using this one.
بدون ماوس زنق
والله ولا بعرف اشتغل عليها انا هاي الماوس.
ساعدك هذا كم فرق
صراحة بحبش اشتغل انا
بس هاي مغطي عليك شوي
هي راضي تصير.
لا عشان مندوب الشركة يجي
لا لانه فيش ماوس.
والماوس اسهل
انا مش ما عنديش لابتوب. أو عندي لابتوب بس حتى معه بالماوس.
بالماوس. انا كأنه بالبيت او نسيه بس انا بالماوس.
هو ابراهيم.
هاي صراحة.
So the reference segment اللي هي attached للreference ring صح؟
Yes.
اللي هي عندنا نحن هون proximal صح؟
This one. هيك مظبوط. هيك.
طيب.
الريفرنس رينج وهذا الميكانيكال
طيب
اكسس.
والاورنج الاوريجن
هاي الاوريجن
وين بتحطها دكتور؟
على الريف
الكورة؟
على مش انت على الاوريجن اوف ذا ديفورميتي هي define the mechanical access place the origin of the reference fragment on the reference fragment يعني انت بدك اياها on the should be in the same in the
توقع
area.
في عندك 2 points هي بدهم يلتقوا مع بعض.
بس انت شو بتقول له هسه؟ بتقول له ها تيجي خلينا نشتغل على الموفينج، تيجي انت بتقول له والله هذا رايحه انا شايف ان هذا بتجيب هذا اللي هو
هذا اللي هو الاكسس تبع
بتجيب بس انا شايف انه مثلا هاي الكورسبوندينج رايحه لاترال شوي مظبوط. هاي الكورسبوندينج وهو بقول لك قاعد انت لاترال 3 ديجريز فارست 10 ديجريز حرك هيك بصير ميديان هيك قاعد بتحرك ميديان لاترال انت ديفورمتي شو رايح حرك.
اول شيء نحن نفس الاكسس تبع السيجمنت.
ايوه
مش ولا تحت
بس هيك صار لونج ديستراكت.
هاي البوينت اللي بتحدد لك صح؟ الكورسبوندينج بوينت هاي اللي بالبيربل صح؟ هي اللي بتحدد لك سترايك دول باك شنو.
انت طلع هو بيقرا لك يعني لو بدك تحرك انت الاوريجن صارت لونج هيك صارت شورت. يعني لما تروح انت بروكسيمال بتكون لونج. بس انتبه على القراءات هاي هون انت بتحرك قاعد كورسبوندينج بقول لك انت صوت لونج رايح شورت لازم تكون ابدا لونج هسه شورت
يمكن لانه هاي على الاي بي مش مبين الديفورمتي، على اللاترال تكون اوضح.
Usually the origin. This time, onto the origin. Obviously, the origin. We'll have to say the origin is. But you. Will be, it's going to go in there today. We want to distract us from the origin.
Ja, die was het dan niet zie dan nog. Daar is het niet. En daar dan ik iets van met
Yeah.
جاهزين؟
هذا الشيء أجزاء مش ضروري.
الأجزاء ضروري. الأجزاء هي راح مثلا نيوترال ما فيش شيء خلاص.
روتيشن سوي أجزاء ما سوي.
تفضل أنت صح. لازم تعمل.
هم عملوا خطوا الأجزاء
كلها مسؤول. ضياء
أنا بعرفش أشتغل هيك، بستخدم ماوس.
بس على نفسي لا
TSF؟ لا والله على الابلكيشن تبعه ما مش عندنا.
اللي هم نفسهم
ما بيعطوك اكسس عليه. لك يوزر باسورد.
هم نفس الشركه قلت له كويس يعمل بريحوني.
انت لو تقول له اعطيني اكسس بيجيب لك من بكره.
لازم 5 degrees 5 degrees internet بس.
قبل اشتغل عليه شيء اول ما جابوا على البازار كان 15,000 من المريض 15. بس ما دام نزلوه تعب مقبول يعني.
في
جاروا ثلاثة أحسن.
عمليات ارثروبلاستي بكلف اكثر من هيك. ريفيجن كيسز ارثروبلاستي بكلفنا اكثر. في ناس بتدفعوا. يعني مرة واحد بيسأل عن الماجنتيك.
أنا عجبتني الحركات هذه أحيانا زي ما بديت بس
الإزرار بيجي. أيوه.
زي تعرفوت يعني تعرف على هذا سهل.
أكيد.
بس قضية
ما مش هالشيء. بس مرة مرتين تعبي هذول.
كنا نروح على الماونتن شباب كنا نرجع.
هاي الماونتن.
أنا دائما عندي
بس تأكد من شغلة واحدة إنه هو لقط شغلة زي بس إنه لقط الترانسليشن رسمها صح فرقت معك صح تمام خليك ماشي مع الوجه عندي خلص الوقت هو على اللي تحت على
ايش؟ وين؟
روح على الريت روح على الريت صرت الريت شباب This is what Gujarat told us to combine axial translation first. يعني أكتب عليها هذا معناه الكلام اللي هو 22%
بعرف على الابلكيشن نفسه
تعمل اوفر رايد ديوريشن
فكرة انت يعني عشان شارع كيف نجيبه
هذا النشيط.
بحترم بتاعه عشان تعبطيه كل شيء هذا هو الشيء
هو لحاله خط. منين جبت الرقم هذا الواحد؟
بس ترى حبيبي معنا كليب ريفيو نعمل ريفيو اوكي يس نعمل هاي هيك
قلت انت مشتري الزهارة وبتعرف تحط الجهاز ستيشن ديفايس وبتعرف شو هذا يعني انت نفس الرجال شانز اصلا ولا تغلب حالك بالدويرات ولا تخلي حالك
ثلاثة
لا وير فوق وير تحت وباقي شانزات شانز بنج
أنا ما بحط الست هذا الأربعة اثنين فوق ما بحط بحط واحد أو 20 ساعة هي لا صغيرة
خلصنا خلينا نشتغل
رياض والله هذا الجروب بيروح على التركيز هناك بدهم يجوا على البرو
عشان يشوف الجملة برا
اللي عنده رقبه هناك بدهم يجوا يعملوا بروجرام عكس هذول يروحوا يركبوا تيست نعم
كيف تعرف انت سريع او بطيء طلع على ارقام انت قاعد تنزل الجنب ما لازم تعدي واحد اثنين ثلاثه بس اذا قاعد تعدي سته قاعد مع
الستركشر ات ريسك خش اعطيني يا ابراهيم ما تصل
يلا نعمل سؤال.
شباب الله يعطيكم العافية، خلصنا السيشن الأول. نعمل هسه سواب نعمل سواب جروب سينتيز اللي كانوا على الماونتنج يروح على البروجرامينج، على البروجرامينج يروح على الماونتنج. بعرف انه كل واحد لسه يعني احنا ساعة واحدة اللي اشتغل فيها صار بيعرف انه انت بحاجة لساعتين او ثلاث. نعمل كوفي بريك. والله كوفي بريك 10 دقائق. It is good idea. عشان تكفي كل الأجهزة مجهزة. معلش ياس وترامي. يا سيدي انتوا خلصتوا هنطلع
That's what I think sometimes to look at it, but slow it down and also help to get structuring this. 2 or 3 social scenes. Change.
Coffee break now. We can start to coffee break now. بدي اشتغل والله ما عنديش حالات. بدي حالات كويس. كيف حالك؟ بقول له كيف قضية
المعاملة حسب المعاملة تقدر نفس الحالة نشتغل نفس ما نسوي القضية بس برنك عليه
قال لي بعد سنتين
هو الثاني صورة الطريق كيف يمشي
وهذا رجال
بقول له طبعا بالما والله كيف اذا شاب يوم العمل يعني والله الدكتور عملية ما جبت واحد جديد
شركة سبونسر اكيد
انت حلفت على يمين ما تبناش في واحنا جاي
مين الشركة؟
بعدين شو المناسب بلانس ايش تمام والله يا حكيم احنا اشتغلنا حوالي 15,000 طلعناها في الشارع يعني تسميه تقنيات صراحة أنا بشكرك وإذا بتشتغل جيبها زين
لا بشتغل
بعدين الواحد اثنين
هوشنا رياض احنا هوشنا صراحة
ما كاش اسبوعين داوم هوشت عشان يشتغلوا
بسبب انك تجيب دخل
من المستشفى ترفع السعر
استرايك الموبيل ارخص استرايك عالميا اسمع ارخص من مدرج الجبنه والله اختاروا ايش؟ عمل سنه جاب 17 اشتراك الجبنه قديش؟ 18 ارخص من واحد
احنا استرايك اللي هو اخر موديل كمان 18
باهنا 15 16
8 ولا 7
8
8
شباب
ايوه عند الدكتور ياسر راني شو السلايكر جديد كنا بدنا نشتري بلد كنا بدنا نشتري بلد صاحب الشركه مدير الشركه عملوا تيبل عملوا سيرفي كان مودع قال انا going with يا مصطفى صلحنا عند الموت
هذا ليش جاي صحيح هذا ليش جاي
هذا ما بعرفش مين قال بالشنكة هذا معي انا جايبه
شو بسوي فيه هذا؟
بالزمانات كنا بنشوف نعمل فيه ستوري بس كان الاقتراح انه لا نعمل فيه ستوري عادي سيرتيفيكت على تريدنج وكذا والتجربه
بغلب اكثر
المنشار وانت تعرف حالك كذا وين هذا راح بعدين يصير
عندك والله اذا سمحت وين كتب طلع ليش مش هروح بديت اللي قديش اخذ فوق
officially got to have a طلع كل
هنا طبعا اكس والله احنا هو شكل اسمع قول له كم كان لبكره يا امر على الشيء
At least once.
خلينا نعيد ترتيب أنفسنا بس اللي كانوا على التابل هون يجوا هون، الثانية يجوا هون العكس، وآخر واحد يجوا هون. I think we can create a new page. We'll start with انت كنت على كل واحد يا زلمه انت وين؟ اوكي تمام. اللي ركبوا التي اس اف في انتروفيشن عملتوه او لا ما بعرف which is very important. جت الورقه هاي اوكي بس انت لازم تتابع لا بتفاصيلها بتفاصيل انك انت شو نوع شو نوع البوستات. I think it's جبنا معنا بس كل ما خلاص ما في مشكله يعني اكيد بعد ما نخلص العمليه لازم تعبي الورقه لانه راح نحتاجها في البروجرام. Password one.
مش لازم مجال مش
هذا هو الكل خلص.
هم بقول لك شغال في الصيف
Should we start now, do you think? Show?
Yeah.
The actual password?
Everyone sit here.
So we're just going to start from a new patient. So on the top here, create new patient up there, and then put in this might be their hospital number or some identifier. And then we're going to give it the name. You know, we need to put in. This is just some generic. I'm going to call this is my frame. This one. But it doesn't, you can put whatever you like, put your name in it. It's just whatever, it doesn't matter what this is.
So I think we can start now.
None of this stuff has to be, you can put whatever you like. I mean, you can even put in a photograph of the patient if you want.
So ready. Now we are, if you go to Barry, if you go just from the beginning, from the top of the screen, yes, we are creating a new patient.
Yeah, I'm just trying to. Yeah, it won't. Oh, there we go. Yeah. So once you've put. Yeah. Okay. So now we go to create new frame. So that's the patient, whoever it is. I'm quite old, 1945. So create a frame. So right at the start, we have to say total residual or chronic. So remember when I talked about you can do chronic correction if you want. I just always do total residual. But if you I don't know. Total residual is much more flexible. So I just use total residual. Frame name, I mean, you can call it, it could be just the patient name, or it doesn't matter what it is. This could be the date of surgery. it's a knee dislocation. And then we have to specify where. So we're doing a right side, and it's a knee.
سامعين؟
Whoops. And then we go to the start of the program. If you scroll right up to the top. And now we're going to go along all these steps to get to the end, but we can't go to the next step until we've filled in the page. Oh, there, sorry. Yes. So we're going to follow these steps along the top, but we can't go to the next step to image until we've filled in this bit here. So the first thing we have to say is we're going to do proximal referencing. You can choose either, but in this case, and Muttasem did proximal referencing, so we're going to choose that. The ring type on the piece of paper, it was a 205, it was a full ring. And it was a 205. So you've got and then the distal ring, again, full ring, 180. And then these strut lengths, so at the end of the operation, I call the struts out, and I get the nurses, they write them on the board, and then I take a photograph. Yeah, those ones, we're going to put those in, because what happens is the nurses then clean the board. So the first thing I say, don't wipe it, leave it there, and I get my phone, I take a photograph of it, and then I say, now you can wipe it off, because it's just there. But I right at the end of the operation. So we're going to, I think it was it? So we're going to have 182. And then select the type. They're all fast fix. So we don't have the smart fix struts here, which aren't really that much better. That's so on the strut.
Yes.
There's like that number.
Yes.
It's 182 millimeters. That's how long that strut is.
It has number.
So right in the middle, there's like a little line which lines up with the scale. And these are fast fix. And then we're going to fill in the rest of the numbers, 163. And that was fast fix medium. 151.
So this is the short. Well, هذا short هذا مين؟
And there's always overlap. There's like 10 millimeters overlap between the long end of the short one and the short end. So there's always a 10 millimeter overlap. So when you'll see, so when it comes to strut change, you have a window of maybe 5 days where you can change it. It doesn't. Usually there's a window that allows you some, yeah, a bit of variation, but there's always some overlap, 10 millimeters overlap. So we're going to fill in the 6 numbers. So that's the hardware. Things like the advanced options. If for some reason we'd fitted strut number 2, say to here, then that's where you would, normally you're just going to put them the center of there's the long tab. But if for some reason we fix it, so you have some options. You can see you can choose any of these holes, but you can't. But it defaults to that position. So you don't. But that's if for some reason you did you changed it. But once we put the numbers in, we've got then we're going to go to images. So on the laptop, it should be, hang on. So I'm going to drag, there's AP and lateral. I'm going to drag it across. And we had this problem. So that's the AP view. Okay, so we had this problem earlier. This one, that little green thing there means it's found the beacon. But this one, it can't find the beacon, even though it's there. And I don't know how we solved the problem. So the beacon is there. I found it. This one it hasn't found it, but it should do. It's there. But I can't remember how we solved the.
He uploaded the image using his phone.
دائما ما تطلع شرط الصح هاي ما تطلع تتغلب وانت تاخذ صوره حتيجي معك اللي هي القريبه بتعمل تراي الوان تكون قريبه لغايه ما بالاخر تصور لا تصور من 6 صور لا تيجي بس لازم تطلع
So we're going to get rid of that one.
So why is that happening? Why?
I don't know. And I have the same problems for no reason at all. But then I maybe save a different version, it finds it. It's very frustrating.
We'll stick to the old system. I'm using the old system, still using the old system. No, without
the beacon. Yeah, I'm slightly with you on that a little bit as well.
Sorry?
I'm a little bit with you on that. The beacon sort of, it's
I can say that. It's not completely.
if it works, I mean, it usually does
used to
work,
that,
but it's like, it's just a bit aggravating, really. I was having this problem, exactly this problem.
I don't have any problem in calibration and in doing or something. I quickly know that. And I use the 6 millimeter space to calibrate.
Yeah.
I don't know why this way it takes the image if you put it like sideways.
So,
I don't know why.
once you've got, we're going to pull the AP view into there. And we just need to make sure medial and lateral. Thank you. And then the lateral view, we'll pull that across. But this one, we have to orientate it. So we can go to the little picture up here. And we want to rotate it. And then we can use this slider
And we just want, that's proximal and distal. And the
عمر لفيت الصورة لفيت الصورة only a moment.
And the anterior and posterior, that's correct. But if it was that was wrong, then we'd have to flip the image. But it's gonna crash. Okay. So this is anterior knee, that's posterior, that's proximal. And this tells us that the x-rays were taken at 82 degrees. So normally we try and get 90 degrees. This is 82, and I think it will accept 65 degrees. But this number up to 65 degrees out, I can't remember.
But I think
82 is fine. Yeah, it's green. So if it was 50, if they were way out, it would be red, and you'd have to take another X-ray. So we've got the images loaded. You then have to choose one of these to be our best orientated image, and they're both pretty similar. So I'm just going to choose AP, but you just have to elect to choose one of them. Go to scale. It's found a beacon here. We have to tell the software where we mounted the beacon. So down here, it was between struts 2 and 3. Yeah, that's where Mutasem fixed the mount on the ring. So and then if we go to the lateral view, it's found the beacon. But if we were, let's say we didn't have a beacon, so then we go override beacon scaling. Yes. So now we're going to choose something. So there's a half pin. We can either choose something round, like a trauma CAD ball, or a ruler. And we're going to say, I'm going to zoom in on this. Whoops. Sorry. So we say this is.
We did not finish the scales. عم يورجيهم إذا ما في beacon كيف يعمل scale.
Because in this situation, the ring has to be orthogonal, right?
It needs to be, yeah. Now you're going like how it used to be.
Yeah, because it will give us both distance.
So I've scaled out, and actually it's pretty similar, but we're going to go back and just use the beacon because we put it there. We might as well use it. But that's what you would do if you didn't have a beacon or it wasn't reading the beacon on that view. Then you could measure, you could scale it yourself off a half pin or.
هذا هون عندنا.
Okay. So we've now got it scaled. Now we're going to go to deformity. There are 3 ways, super dot or trauma dots, but what I use, which is like the classic Smith spatial frame, is just origin and corresponding point. I know the trauma dots is you're using like a fracture, they're trying to reduce a fracture, but I tend to use the origin and corresponding point, and was the same, and that would be like the original sort of classic TSF method. So we just click on origin and corresponding point. We can change it if we want to. So we have to, it's unfortunately this screen covers the X-ray and it's super irritating. Okay. Okay, fine. So our origin, our reference fragment is blue. And we're going to put this on the femur, down the line of the femur. And the origin is this little origin, and we can slide, whoops. This is on the femoral side. We're doing the proximal referencing, we're on the femur. And so the origin is anywhere on this line, and it's probably about the end of the femoral condyle. We can't really see it on this view, but we're choosing, we want to line up the middle of the tibia and the middle of the femur on both AP and lateral views. So the origin will probably be somewhere about here. We can adjust this later if it's not quite right. Is this roughly where you chose it, or your origin?
Yeah.
Somewhere around.
Or somewhere on the mechanical.
Somewhere on the mechanical axis, but probably about where you think the end of the femur is, the end of the femoral condyles. And then we're going to come through to the lateral view.
The moving signal.
Responding.
Yeah. Oh, sorry. Yes. Yeah. Sorry.
So the origin of responding is super important. If you are telling the program that the corresponding is proximal to the origin, so please move it down, move it down, medium. So this circuit effect should overlap that or should be together after collision.
Yes.
Now the current situation, they are not overlapping each other. So this is very important. So this axis, the green one on the distant fragment.
So probably the back of the tibia, we know the tibia is dislocated, it's gone up the back of the femur, and I think you can just about see that the tibia is coming all the way up here. So that's probably where, and all the software will do is it'll put the purple onto the orange circle. You just move those two together.
What is the parameter? So we are in the deformity of valgus 10 degrees and lateral 9 millimeters and short 15 millimeters. That makes sense. So the origin corresponding sometimes we can make mistakes because we are doing the combined. So you have to be careful that you are short. We are really short because we don't use it. So I think that's correct.
Yeah.
We can proceed for the lateral. We know that it's short.
Maybe this is a right example.
So once we're happy with the AP, then we're going to go to the lateral view. And the same thing. We're going to draw a line up, reference fragment on the blue. Yeah, probably, yeah, I know. Whoops. Oh, yeah. So that's the, and then the origin. Sorry, I'm going to make this a little bit longer. The origin, I say we probably want it to have right at the end of the femoral condyle. Because we want this, the tibia to come down around and end up. So those 2 points are matched. Yeah.
Terminology there, the proximal fragment.
So now this, and then the corresponding point is the top of the tibia, probably about here. And if we put it further up, it will distract it even more. So I would, if in doubt, we want to go, I'd rather over distract this than get a collision.
What is that? So it is about 40 degrees of friction. That makes sense because our patient is like that. It is 3.5 centimeter. That makes sense.
Tibia is flat.
It is over.
Yeah, maybe a little bit more, less than that, too much. So I'm going to move this down. You can see as I slide this up and down, it's about. And then finally, axial view. So was there clinically any internal, external rotation? We're not going to get this off an X-ray. This will be a clinical assessment. I think you said there's 5 degrees of internal.
The last one.
So we can.
We are telling the patient this is internal 5 degrees.
So I'm just sliding this across. Yeah.
I find this difficult. Really, I can't understand. I use the virtual hinge.
Okay.
Is it easier? Maybe because I'm familiar with it, I find it much more easier. You know, I need to turn everything around this part.
I think that probably the most, it doesn't matter how you do it, but I mean, I just do an origin corresponding point, but the virtual hinge or the super dots or the corrigin, you know, it doesn't, there's lots of different ways which people have described how you, and how you, which way you use. It doesn't matter, you just use whatever works for you and what you're used to.
What you used to
Yeah.
the virtual hinge. Still there, right? The virtual hinge. I still can use it.
I haven't, I mean, I'm aware of it, but I haven't particularly used the virtual hinge. I try and just same thing, origin corresponding point, but you know, it's like they had this sort of super dots method or the trauma dots, and that's, you know, it's fine.
Can you shift to the super dot like this? Super dot. So this is the super dot.
So this is the super dots.
So you tell him.
So you'll have to tell me what to do. Place points to draw a closed shape around the moving bracket.
Yeah, that's method I use.
Okay, so we're gonna have, there's our. Yeah, I'd probably not too bad that. And I guess you can change the, you can. Places to about location. Essentially, I guess we could sort of say, well, the end of the femoral condyles. And then.
Yeah, the same. You do the same thing with the lateral.
That's got no.
End of the femoral condyle.
And then that's still our. And then the super dot will be
maybe a femoral condyle here.
We've got to put in the line on this. This has to go on the. Yeah, you know, this will create our that gives us the. See, everything's coming up as 0. It's no deformity. I'm not doing it right because I don't use this. So we're going to go back. I'm going to change it, I'm afraid.
It's the origin of
Origin probably about here.
الفيلم شهادة من هون، شهادة من تحت، شهادة من هون. روح رفع شهادات في نفس اليوم. شاطر.
So we used to insert the amount of deformity that we need to correct. Does that still exist in the system?
Yeah, we're going to
So I need to, for example, to start, to extend, and to do that.
so if you want to lengthen this, we would say that let's say you have let's say you're going to have a 5. So we just take an AP view. We can sort of say our osteotomy is, we're going to do osteotomy here. Our origin is here, but our corresponding point is 5 centimeters. That distance there is 5 cm. And all it does, it puts that point to that point, which means that the bone will move down by 5 centimeters. So it thinks
Depends where.
it thinks that the origin is up there, which is, so that's how it will lengthen by 5
So
centimeters.
I can't tell him lengthen 5 centimeters. I'd like to tell him lengthen 5 centimeters.
Yeah, so you just you put in that the origin, the corresponding point is way up here. It's 5 centimeters too high.
So, please, we have reached this page mounting. We are going page by page. The mounting, only you check that this line is correct. المنطقة مظبوط رسم اللي هو البروكسيمال فلاج, which is the one is that difference maker. Okay.
And then the lateral view. So you can see the lateral view. So it draws it on there automatically. If for some reason it hasn't drawn it very well, if you do override automatic now, skip to. So now I've done. Now I can make this ring bigger or smaller. I can rotate the ring. But normally you don't have to do this because the system automatically does it. So I'm going to revert to automatic mounting and it draws it in. But if for some reason it wasn't quite right, you could do it manually. Or you didn't maybe guess it, you didn't have the beacon, you'd have to do it manually. And then the axial view. Yeah. So it's just said that the proximal ring has been rotated inwards by 15 degrees. And that's just set. That's got that from the beacon. So everyone okay with that? So yeah, normally it draws it pretty good and you don't have to change it. So we're going to distract this at 1 millimeter a day. You can choose any number you want, but I always basically just choose 1 millimeter. I never really go faster than 1 millimeter. Occasionally I might go slower. Or you could say, well, we want to do 1 degree a day, but this is mostly lengthening. And then because we have to lengthen this tibia before we can get it round, we're going to do axial translation first. And this is the waypoint. This is the waypoint. Otherwise, it's going to just put the two directly together, but they can't go. There's a bone in the way. Yeah.
Only one take, we change it.
And we'll see that. And then the structure of risk is this little, we can put this wherever you want. And so you have to think, well, what is the structure of risk? And actually, it's best to see it on the lateral view. It's probably back here. You know, there's a sciatic nerve, there's a popliteal artery coming down the back. So on the lateral view, it's back. On the lateral view, it's somewhere at the back here. And on the AP view, it's going to be in the middle. We're looking through the tibia, the femur, and it's behind it. So that's, we'll say that's it on the AP view. We'll have to set that. And on the lateral view, it's probably going to be about here. Obviously, it's a three-dimensional structure. The popliteal artery or the you know, obviously the sciatic nerve is split, probably higher up. But you have to, and that just means that rate of 1 millimeter a day, that point in space, that's what's going to move a millimeter a day. Other parts may be moving faster or slower than that. If this was
لكن structural risk تقدر تحسب انه عند هاي النقطه ما راح يزيد عن واحد. اعمل كل حساباته بحيث انه ما يطول لك.
So if I was doing a lengthening, my structure of risk, I would just choose the middle of the bone on the AP at the level of the osteotomy, because I want that bone to lengthen a millimeter a day. If it was a leg, say a valgus, I would choose probably the common peroneal nerve, like on the edge of the fibula. So sometimes your structure of risk is the bone, is the lengthening or the fracture. If you're reducing a fracture, for some reason you're doing it slowly. But sometimes it's a nerve or a blood vessel, but it's usually a nerve. So in this situation, it'll be somewhere out the back of the knee. Yeah.
Finished.
So we've specified our structure risk, and then we're going to go to the preview. So you can click on this and spin it round. So that sort of looks similar to what, now it looks like the two bones are connected together there. They're not really, but this isn't the actual patient's x-rays. This is just a generic, it's drawn it too large. This is a child. And then we can go to the, this is going to correct over 80 days. And you can see that it's putting the length in first, distracting it. Then it's going to start going round. So we've cleared the posterior femoral condyle. And now we're bringing the correcting the alignment. So this is 82 days, quite a long, so we can go back. And if we draw down here, but down at the bottom, duration, 82 days. I usually do optimized for anatomy. I don't really know what the difference is, to tell you the truth. But so we'll sort of say, actually, we don't want to do it in 82 days. We're going to do it in 30 days. So the first thing we see is now we're not moving a millimeter a day, we're moving 2.73 millimeters a day. See, that's changed down there. I think that's quite fast. I mean, you know.
But your deformity is very big. 3 centimeters.
Yeah.
So, but also, you can always override. I myself, I always override.
I often will override, but I'll usually go longer, not shorter, but it doesn't matter. But so now we've gone, so we'll go to next, and it'll give us a warning. It'll say, "Are you sure you want to override it?" No, you're going faster than what the program is setting. Yeah, we're fine. So now it's 28 days, which was what we specified. It's still the same. It's still the same distraction coming round, but it's just happening in 28 days rather than 80 days.
And this, what this shows, the point of that blue bit, that's our origin. And the tip of that green one, that's the corresponding point. And all the software does, it puts those two together. It doesn't know, and that's all it's doing is putting those two. Just scroll around. Okay, I can't. Yeah. But that's all it does. It doesn't know anything about bones or software. So it puts the corresponding point to the origin, which is that point there. But we can make it look beautiful. And have a picture of the bones. And then the final thing is we go to the prescription. And this is the bit which we're going to print out. So we've got so right at the start, we put our date in today. And then today is day 0. And then tomorrow, this is what the patient had got. There's 6 struts. You print this off. There'll be save it as a PDF somewhere. And these colored segments, this is when we need to change the struts, longer or shorter. So we've got 1 day here, 27 November, we can change all 4 struts. Same day. So that's when we get back to clinic. And then there's another strut change down there. So we've got. But if we push this through, sorry. If we go with the 82 days it recommends, the overlap, it'll be really stretched out. We've got before we had like 2 days, now we've got 3 days. Down here there was before it was 2, now we've got 5 days. So there's a much slower, it stretches it out, so there's some flexibility. Because you may say, well, I'm only got a clinic Tuesday.
That's not will live longer.
Yeah. So I will often
We will decide the duration in your clinic according to your clinic.
So I might stretch it out. Oh, there may be a day.
This is the day you change.
Yeah, you have, because the struts, there's overlap. That's when you've got to make the strut. Yeah, you have to, you've gone up. So once you go to 153, now you're on the medium strut. Right at the bottom here, it says we're going to change strut 5 short to medium. And so we have these, it gives us a lot of overlap. So that's 3 days there. Obviously, you could do them in this patient and change those in, and they could come back 2 weeks later and change those 2. But I try and get into a clinic when I can change all the struts.
All of the same.
Yeah. But it's the same thing. You always have to have the thick struts. So you put one in, pick it down.
you know, review the prescription. And then this is what you're. This is what the print off for the patient. Yeah, this chart.
I think it is now.
Yeah. Yeah. Sometimes what I do. Let's say there was just one strut change. Let's ignore those ones. We just had one structure change, and they finished at 152, but they couldn't come back to the clinic for a couple of days. So I would sort of say, okay, keep going with other ones. This one, just stay at 152, and we get to the clinic. Change structure, and we catch up for 2 days. We get into. We should be on somehow forgiving. Yeah, a little. Yeah. So I do that sometimes. I'll sort of say, okay, you're gonna. That strut will run out of length. We'll get to 152. You can postpone. Yeah, so I just say, okay, hold that one. Don't change that one. You can't. Going with these ones.
On the same as the patient.
Yeah.
Visits.
Yeah, yeah. And then I say, when you come to the clinic, it'll be on 152, right? It should be on 154. We'll put in the new strut, and then we're immediately in the thing to get it to 154. But then they're back where they should be. Yeah, yeah, yeah. And usually I look at the numbers so that one is 1 millimeter, one. Most of these are, so some of these struts.
It's 1 millimeter in one dimension. One strut. So
yeah.
This one than 1 millimeter.
Usually I'll do the struts. 1 or 2 or 3 millimeters is okay. If I'm doing the correction, it's suggesting that something's moving like really fast, like 5 millimeters, then I'll slow the correction. I'll override the correction and go slower. Because it just slows everything down. Because a couple of 1 millimeter or 2 millimeters is fine, is okay. If you do more than that, it starts to get a bit uncomfortable. Yeah. So I'll slow it down. I think it's moving too quick. It looks like.
The purpose of that is to slowly, not to go fast. It's not a good connection.
Yeah. So this one, it's all competition, there's no bones. So we can correct this over 100 days, whereas obviously if we're lengthening a tibia, can't go too slow, otherwise the bone will unite. Yeah. So it
can be too strong.
Then I say to the patients, look, I may say to them, if it's sort of really painful to stop, just take a break for a couple of days and then restart. So stop here, and then you carry on, but instead this date will be a little bit narrow. I also say, don't stop too long, because if you wait too long, that gap may hit feeling the bone. And also, if you have a break here for 3 days, you're still going to have to put it in.
The next day,
you've got to compensate. I usually just let them carry on, but they're just 3 days behind, and eventually they get to the end. The struts are correct, but the dates they've taken a break.
Like you take 2 or 3 days.
I usually just let them carry on, and then again, an extra 3 days.
At the end of the fellowship of this workshop, كان تفضل ياس ولا دكتور تحقير يعني مصر انه صح المريض خلاص. دكتور احمد المهير. Thank you everybody for this workshop. Really, I am so proud for this participation from all, and also the great contribution from Mr. Barry and from all mentors here. I'm pretty sure that TSF needs more time than a single day workshop. And at least you have to practice some cases in theater and doing that on real patients. Now we are going to distribute certificates for attending this workshop. At any time, even if anybody wish, we can communicate and you can come to us. We are doing some TSFs. It's not frequent, but we are doing TSFs around 10 cases maybe per year, maybe less than 8 cases, something like that. Anything you can contribute to Hatem?
First of all, I want to thank Professor Harry for presenting this course. I would like to thank you so much for this interesting presentation that you did for us. وأنت أشكركم شبابنا يعني على هذا الحضور يعني وعلى هذه النشاطات اللي فيها. وأنا بدي أشكر الدكتور معتصم على هذا الجهد الكبير اللي عمله. حقيقة نقول الدكتور هاشم والدكتور إياس هم الثلاثة اللي سووا الكورس. أنا كنا بس بنتفرج عليهم.
Certificates. Take some pictures. Can we get them all of us? Just take one big ones for the whole participants.
Yeah. Okay.
Okay. If you can just in front.
Yeah. اكثر من صوره من اكثر من صوره ارجع انت لورا ارجع لورا ارجع لورا It was nice to meet you. It's not that you were lectures. هي الأربعة من الكيل That's mostly.